My topic is delivering unaberrated vision, role of aborometry in cataract surgery. Now, as we know, cataract has evolved over the years from couching to ICC to ECC to SICS to phaco. Right now, with the invent of premium IOLs and femtosecond laser assisted cataract surgery has become more of a refractive surgery. In today's era of perfect vision, patients demand not only 20/20 vision, but exemplary subjective quality of vision too. So, as we know, this is our normal optical system. But if there are any imperfections in our optical system, which causes poor quality of images, it is known as an aberration. Now, aborometry is the principle of recording these aberrations, which can be either done by a forward projection or a backward projection. The Shering's principle helps us is a way of a forward projection aborometry. The ray tracing is also a forward projection, whereas the Hartmann-Shack and the dynamic stereoscopy are backward projection methods. Now, how does this help us in our cataract surgery? Starting off, we'll talk about how it helps us in toric IOLs. So here we see an aborometry done on the eye trace. What do we see here is it gives us all three, that is the internal, corneal, and the total aberrations of the eye. Here, it also gives us a tracy refraction and the higher order aberrations. Now, if we take a case example here, the cylinder here of the patient, when what the patient is accepting is a 0.25 diopter, but when we did his pentacam, his astigmatism is coming to 1.4 diopters. Now, why is this discrepancy there? So should we actually go ahead with a toric IOL or a simple monofocal IOL in this patient? The role of aborometry helps us here. What we see is that the patient has a high amount of corneal astigmatism, which is being compensated by the lens. Now, that is why the patient is accepting a low total astigmatism. In this case, once the patient undergoes cataract surgery, the lens will automatically be replaced and the corneal astigmatism will be manifested, and hence we should go ahead with a toric IOL in this case. Coming to case example 2, here a patient shows a cylinder, accepts a cylinder of -2, has a high amount of astigmatism on the topography. Also, there's no discrepancy. Straightforward, a toric IOL can be implanted in this patient. The aborometry of such a patient shows you that the patient has only corneal aberrations with minimal lenticular aberrations, and hence the high astigmatism also, which is seen on the topographer. So again, coming to a third case example, here the patient has a cylindrical, a cylinder acceptance of 1.75 diopters, but a very low corneal astigmatism here. Again, a discrepancy arises. Again, we don't know whether should we go ahead with a toric or a monofocal IOL. Here, the role of aborometry shows us that the patient has low corneal astigmatism, but a high amount of lenticular astigmatism, due to which the patient has a high total astigmatism. And after cataract surgery in this patient, the patient can be very well treated with just a monofocal IOL and a non-toric IOL because the patient's corneal astigmatism is low. Now, the eye trace also gives you a pre-op planning station. It also captures a reference image, which helps you to compensate for cyclotorsion when the patient is in a horizontal position. Coming to multifocal IOLs, again, you can do an analysis of the aberration profile. Here we see the patient has significant corneal HOAs, and in such a patient, a multifocal IOL is best not implanted. It is said that if the aberrations are more than 500 microns, the patient is not a suitable candidate for multifocal IOLs. In this patient, we see the patient has very minimal corneal HOAs, and such a patient would be an ideal candidate for multifocal IOLs. For multifocal IOLs, another recent publications tell us that it is important to study this angle alpha. Now, what exactly is angle alpha? Here we see the blue cross denoting the center of the limbus, the red cross the center of the visual axis, and the green cross the center of the pupil. The angle alpha is the angle between the optical and the visual axis. If in normal conditions, this should be between 0.3 and 0.5. If the angle is more than 0.5, such patients are not good candidates for multifocal, and are the ones who would typically complain of negative dysphotopsia like glares, halos, and all post-operatively. So here, if you see a case example, you can see that once the IOL was implanted, because of the large angle alpha, how widely dispersed the third and the first Purkinje images are. And so this patient was not a good suitable this thing for MFIOL implantation and had a poor image quality due to the misalignment of the axis. Here, if you see, this patient has the first and the third Purkinje images so close to each other with an angle alpha of just 0.1. That is a good angle alpha, and hence is a good ideal candidate for MFIOL implantation and would have good amount of image quality post the MFIOL implantation. How does it help us in Ioselection? Now, it is well known that the cornea is usually prolate with a negative Q value of 0.26. Post myopic LASIK, these patients the cornea becomes oblate and the Q value becomes positive. If you see here, these patients have a positive spherical aberration, and hence implantation of aspheric IOLs with a negative spherical aberration should be done in these patients, as compared to a post-hyperopic LASIK, where a patient has the cornea post the hyperopic LASIK becomes more prolate. Therefore, the patient has more amount of negative spherical aberrations, and hence an implantation of spherical IOL with a positive spherical aberration should be done. In patients of post-RK or in decentered ablations, where there are higher order aberrations are outbounds, in these cases, you should just go ahead with a zero spherical aberration IOL. Coming to DLI, it's called a dysfunctional lens index. Here we see a clear lens, and yet the patients there are with a 6/6 vision and an N6 complain of glares, halos, and starbursts and difficulty in night driving. So why is it that even though their lens is clear, that they complain of this? It is something known as dysfunctional lens index, which takes into consideration the internal HOAs, the pupil size, and the contrast sensitivity. It is a new parameter that judges that even though the patient is giving you 6/6 vision and there are no significant visible changes on the slit lamp, the patient here, if you see, has a level of 5.78 DLI, which means that the patient has started showing early lenticular changes, and they can go ahead with the cataract surgery in this case. Anyone above the level of 5 should be considered for a cataract refractive lens exchange, and lesser than 5 should not be. Now, coming to decentrations, here we see how the Purkinje images are widely spaced from each other. They have increased HOA, so poor quality of vision. We recentered this patient, and you now see how good the closely spaced the images are with minimal HOAs and a good quality of vision. Now coming to the toric IOL alignment, the eye trace also gives you a post-op toric IOL alignment. Here we see that the desired axis was 102, the measured axis was 108, so a 6-degree misalignment here. In cases of large rotations, we know that there is a lot of reoccurrence of the cylindrical power which takes place, which is also given by the eye trace. Now coming to the next case. The next case is here we see that in PCOs and in case of glistenings, patient have high amount of lenticular or internal abrasion, but minimal corneal abrasions. These patients post a YAG, or in case of a glistening, a removal and an explantation of the glistened IOL and a reimplantation of a monofocal IOL would do very well. Coming to lenticular conditions, this is a case of a coloboma. Again, here we see high internal or lenticular abrasions, whereas minimal corneal abrasions. A refractive lens exchange, a clear lens extract would significantly decrease the internal abrasions here. Finally, coming to a lenticonus, again, high internal spherical abrasions. Post a clear lens extraction, patient is much better with minimal amount of internal spherical abrasions. Hence, aborometry can help us in many ways, even in our cataract surgery. Thank you.